Hello and welcome to the ASCO Daily News Podcast. I'm Dr. Monty Pal. I'm a medical oncologist and professor and vice chair of medical oncology here at the City of Hope Comprehensive Cancer Center. I'm also host of this podcast. Today, we're going to be talking to somebody that I consider to be my little brother, if you will, in oncology, Mina Sedrak. Mina is an expert in the area of cancer and aging, which really includes the development of drug therapies and technologies that help enable older adults and survivors to live longer, healthier, and more vibrant lives. Really excited to chat with him. He's an expert not just in cancer and aging, but also breast cancer. He was my former colleague here at City of Hope before he moved over to the UCLA Jonsson Comprehensive Cancer Center, where he's an associate professor and director there of the Cancer and Aging program. Dr. Sedrak's research involves mechanisms behind cancer treatment-induced accelerated aging and really aims to take this science into more of a therapeutic direction, which I am super, super excited about. Mina, thanks so much for joining us today. And just FYI for our listeners, we have all of our disclosures in the transcript of this episode.
Thank you, Monty. Thank you, Dr. Pal, for having me. I'm really excited to be here.
I feel like we have to go on a first name basis here with how well we know each other. So, Mina, you and I together have witnessed this evolution in cancer and aging. I mean, both of us work together here with just a legendary figure in the field of geriatric oncology, I'll call it, Dr. Arthi Huria, mentor to me, mentor to you, mentor to so many. Can you give us a sense of where cancer and aging has gone since the time that you and I started here together at City of Hope?
Dr. Huria and her collaborators, Dr. Dale and Dr. Mohili, they were huge pioneers in the field. They were one of the very first people to kind of highlight the importance of looking at older adults beyond just their chronological age and their comorbidities, and moving us beyond just seeing patients and making decisions using what we call the eyeball test. Oh, this person looks fit or not fit, frail or robust, to really using objective measures to assess our patient's health status and incorporate that assessment into our evaluation of the treatment, prognostication, and discussions with our patients throughout the cancer continuum. And so that is what geriatric oncology has and continues to be. And it's a huge important part. And their work has laid the foundation to show that when we look at our patients beyond just their chronological age, and we look at their functional age, and we do these objective assessments, we can gain much more deeper information to tailor the treatment for our patients that's sitting in front of us, rather than do a prescriptive treatment or a over or under treatment in that population. So that's sort of where the field is growing. And a lot of the work now is how do we implement that? How do we put that into clinical practice?
Let me spearhead that discussion, right? I have these moments when I go to the ASCO annual meeting. I remember this happened to me a while ago when Jennifer Temmel presented that terrific work around early palliative care interventions, right? Or it even happened to me this year, right? When Christopher Booth presented the challenge trial around exercise and colon cancer, these amazing, I'm going to say simple, they're not simple, but they're simple interventions relative to, some of the complex drugs and mechanisms that we're using nowadays to really help outcomes for our cancer patients. The big question becomes, how do you implement, right? But my understanding is that there's easy ways for us to take tools in cancer and aging and sort of plug them into our daily practice. Am I right about that?
Yes, and that's something that the Cancer and Aging Research Group, which was founded by Dr. Huria and now is co-led by Dr. Dale, Dr. Mohili, and Dr. Kleppen. They have been incredible at really trying to develop practical tools like the practical geriatric assessment, which is now endorsed by the ASCO and other NCCN or guidelines. And so there are tools that are becoming more and more practical to help incorporate that into clinic. Now, what might be practical in a resource-intensive setting may not be practical in some of the limited resources, whether it's rural and or other countries where the resources may be more limited. So that's why Christina Burgood, Enrique Soto, and others have been really working hard. There was actually a really beautiful paper that was just published in the Journal of Global Oncology where they have shown that there are guidelines about how to implement these tests, these tools, these assessments in clinical practice, even in different resource settings. So I think we're going to get to the future where this is much more, and it's definitely important, but it's much more easily incorporable into our practice.
Yeah, you know how close I am to Chris, and I was so proud when I saw that paper come out. That was really exciting. I skimmed it. I have to tell you, I didn't get into the weeds, but it was apparent to me that, some of these geriatric oncology tools are things that, I could probably plug and play into my practice where I'm double and triple booked over, most slots, right? I mean, I could still probably afford a little bit of time or maybe have like a nurse or an extender kind of help participate in the evaluation process. I thought that was, really, really interesting.
I'll just say that at UCLA, we are working with Arash Naeem, who is a geriatric oncologist, and he has developed an AI platform where the assessments can be done by an AI computer. So it's like talking to your chat GPT. They can talk to you, and for a few minutes, they will ask you the question. So you don't even have to fill it out on a piece of paper. You could give the patient a little iPad, put them in a private room while they're waiting for their doctor and get the results, and it's right there for you. And so we've been trying to think about how can technology help with the completion of the assessment, at least doing that. And I think it's been very cool. We did a pilot study. He's writing that up, and we're going to continue to do some of this exciting work. How do we think about AI in the context of this? And, older adults, they're not like what they used to be. A lot of older adults are very familiar with and comfortable with phones and computers and iPads, much more so today than they were even at the time when Dr. Haria was alive.
That's so interesting. You mentioned this. The AI approach is something I've been thinking about in this context. Because what if, for instance, we've got video monitors all over our hospital, right? What if you're actually just taking a look at that patient as they make their way towards your clinic, capture that video, use an AI algorithm to say, hey, the time to get up and go test in this patient is not particularly good based on what I'm seeing here, right? There's so many ways to stir the pot and come up with creative ways to get these tests done.
That's right. And Arash is looking at also sensors. So he has some studies where he's putting sensors inside people's homes where they would put them like on top of an Alexa app or the equivalent. A lot of people have these apps, and basically they can sense how you're moving around and what you're doing, just movement wise. And then they can collect that information to gain information about your life beyond just what we're seeing in the 20-minute visit in the clinic. Even when I do a walk test where I get gait speed or physical performance, short physical performance battery, the chair sit up, those are oftentimes a single cross-sectional static measure. But what about the dynamic ability of capturing what's been happening for the last 7 days? What's been happening for the last 25 days between the visits, between the cycles of chemotherapy? And could that inform how I make decisions when I see patients? And who do I need to target and identify? And so we're very excited because really at UCLA, Arash is leading the technology efforts and thinking about implementation of these important measures and these important tools, but leveraging new technology. And we don't want to be behind. We want to be ahead of the game.
I love that idea because there's a Hawthorne effect, isn't there, where you observe a process and it naturally gets better. I mean, when you ask that patient to get up in the clinic and move, they're probably functioning the best of their abilities, but we'd probably learn a lot from just watching how fast that patient picks up a remote control at home. Some simple movement like that that's volitional would probably help out a ton. And I got to tell you, it's so funny when you mention Arash Naeem's name. I distinctly remember him serving as an attending on the wards when he was brand new at UCLA on faculty when I was a resident there. And his dad is a legendary hematopathologist, right?
I didn't know that.
Yeah. Farmars Naeem wrote the book on a lot of heme path malignancies. Incredible guy, very, very storied hematopathologist at UCLA. I could probably go on this topic forever, but in the interest of time, I'm going to shift to something that, again, I could probably talk about forever, which is this area of senescence that you're involved in. You'd mentioned this to me, I'm going to say during your outro from City of Hope and towards your transition to UCLA. It is such an exciting area. I mean, understanding the actual biologic process of aging and using those underpinnings to really sort of tailor therapy. So tell us where the state of the science is there with this body of work that you're doing.
As I said before, we have tools now to assess patients and to then do something about the deficit. So if a patient is falling, what we do is we refer them to physical therapy where they can do fall precautions and strength training to give them the information. But all of these supportive care interventions are very important. They're great, but they oftentimes are not targeting the root cause of why they are happening. And so that's really where I have been very interested in how can we understand, well, why is it that something like chemotherapy or immunotherapy is causing a decline in cognitive function or a decline in physical function? And so that has really led us to think about geriatric oncology rather than a discipline of older adults, but to think about aging as a physiologic process. We are all aging. As every day goes by, we are aging. And what that means is that our bodies are accumulating damage, the cells are being exposed to various stressors, and the repair mechanisms are declining. And as we get older, it's really more damage and less repair mechanism at the cellular molecular level. And it turns out that these processes of how our cells repair and respond to damage are fundamental processes of biological aging. And there's been a large amount of preclinical and now really exciting clinical work to show that there are hallmarks that could be used to assess the rate of which we age by looking at these processes. And that includes things like epigenetics, telomeres, inflammation, and something called cellular senescence. And we've been interested in my lab in senescence because it's a unique process that has an important role in aging, but it also has a really important role in cancer. Senescence is a cell state. Cells, when they are stressed, they respond to entering this state of senescence. This stress could come from anything. It could come from an oncogene activation. It could come from a reactive oxygen species. It can come from a direct damage to the cell. But it's a cell state, just like apoptosis, necrosis. Senescence is a state in which the cell, in response to that stressor, undergoes an arrest from the G to the S phase. And that arrest is oftentimes associated with a resistance to apoptosis. So then the cell doesn't die, but it's alive and it remains metabolically active. And in fact, downstream pathways of these cell cycle inhibition of this G to S phase lead to the increase of these transcription factor in the chromatin and lead to the development of these pro-inflammatory factors. So these cells, which can occur in various tissues in the body, can continue to live despite having developed these changes. And then they secrete these pro-inflammatory molecules like cytokines, chemokines, metalloproteinases, all of these, which are called the senescence-associated secretory phenotype, or SASP. And as we age, we accumulate more and more of these cells. And our bodies are no longer able, our immune system, like macrophages and T cells, are no longer able to remove them effectively. And as we accumulate them in various organs, these organs release a lot of inflammatory cytokines, and the chronic inflammation in that tissue leads to the tissue to be damaged, and it doesn't work as well, and then it starts to decline in function. And that is believed to be how senescence plays a role in aging. It's the accumulation of senescent cells that occurs with increased damage, and then the repair mechanism of clearing these cells effectively, which then leads to buildup of inflammation, and chronic inflammation leads up to damage in multiple tissue.
This concept to me is fascinating. And I guess the big question is, senescence is bad, right? Is it not reasonable to think that this body of research, I mean, if you're able to sort of have a meaningful impact on senescence, it could have implications well beyond oncology. Is that fair? I mean, you really could extend lifespan all around. Is that reasonable to think, all-cause mortality?
100%. And that's what they have been shown in animal models. So when they are able to, and the reason senescence is exciting is because it turns out that you can target these cells and you can induce apoptosis of these cells, but it requires active targeting of various pathways, but it can occur. And when it does, and it's done either genetically or pharmacologically in mice, we see that the mice can reverse damage. So if you take an old mouse and you genetically engineer it to remove senescent cells, that mouse will go from being frail to fit. And if you take a young mouse and you induce senescent cells at a high rate and you accumulate them in that mouse, even though it's young, will become frail. So that has really led to this exciting opportunity is, can we translate this finding that we're seeing in animals and in vivo cells, cell cultures, into humans? And could that have a benefit beyond just one disease? Could it have a benefit in multiple diseases and not just really longevity, which I think it would be great, but what people are really looking forward is, how do we live healthy as we get older? How do we move the curve so that people are not developing chronic diseases in their 60s, but they're developing them in their 80s, towards shortening the period of their life with disability, rather than what we have currently, which is people are living to 70, to average life expectancies in the mid 70s, but they're spending 10 or 11 years in disability of that life. And so how could we reduce that time frame?
This is brilliant, Mina. And for our audience, this compelling dialogue that we've had here, thankfully, is translating to funding for Mina's work. He just scored in the second percentile for his NIH R01 based on this topic. We're so proud of you. I mean, this is just remarkable work. It's not easy in the current climate to get funding, and a second percentile score is just absolutely wonderful. You know, Mina, I could probably go on for you for a couple more hours here talking about your work in cancer and aging. I think I'm going to have you back on the podcast here. But a million thanks for sharing your thoughts here today on the ASCO Daily News Podcast. And thanks to our listeners, too. If you value the insights that you heard today on the ASCO Daily News Podcast, please don't forget to rate, review, and subscribe wherever you get your podcasts. Thanks, Mina.
Thank you so much.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.